Hey, good morning, everyone, and welcome to this morning's webinar. Today we have two exciting speakers that will be speaking about pediatric urology. Two of the topics that we're covering are both rare and more commonly encountered pediatric urological conditions. Our first speaker is Dr. Abdullah bin Hadirah. He's a fourth-year pediatric surgery registrar at the Red Cross Children's Hospital, who's currently rotating through urology with us. Abdullah will be covering or speaking on the topic of rhabdomyosarcoma, which is an uncommon but important entity that presents significant diagnostic and management challenges. And it's a nice collaboration or multidisciplinary collaboration between urology, pediatric surgery, oncology, as well as radiology. Abdullah, thank you for joining us, and you can start your talk.
Thanks, Amman. Okay, so I'm going to share my slides now. Okay, can you see my slides?
Thank you. We can see it perfectly. You can start.
Yeah, sure. Thanks. Okay, so today I'm going to talk about paratesticular rhabdomyosarcoma. So first, we'll start on rhabdomyosarcoma in general. So the most common form of soft tissue sarcoma, and it's the third most common extracranial solid tumor in children. So paratesticular rhabdo is originated from mesenchymal tissue and has bimodal distribution of age from 2 to 6 and then 10 to 18 years. The younger patient will have more embryonal histology, and for the older patient, more alveolar histology. So it's mostly sporadic, but there is some associated syndrome, just to mention here in the list. For staging, it's a bit complicated because we have a pre-treatment staging and we have the clinical group and then the risk stratification. And we have a favorable site and unfavorable site, also histology, favorable histology and unfavorable histology. But in the pre-treatment, we'll cover the favorable site like orbit, head, and neck, excluding the parameningeal, genitourinary, non-bladder, non-prostate. And for A, less than 5 centimeter, B, more than 5 centimeter, the tumor size. And N, if there is lymph node, or NX, it's unknown. So any patient with favorable site, if there is no MITS, it will be in stage 1. And then you have the unfavorable site. If the patient has tumor more than 5 centimeter or positive lymph node, will be stage 3. Otherwise, will be stage 2. And then any patient with MITS will be in stage 4. So for the clinical group staging, as it assesses the resection and also the lymph node involvement and the MITS also. For the complete resection will be group 1, and group 2 will have either positive node or microscopic residual, and the group 3 will be macroscopic or biopsy only, and group 4 will be distant MITS. Risk stratification, this is a bit complicated table, but I just want to mention that the updated 2022, they added the fusion states in the risk stratification. So mostly the patient presented with painless scrotal mass and might mimic hydrocele. The other differential diagnosis will be other testicular tumor, germ cell tumor, or a torsion, or epidemo, or orchitis, or hydrocele. So if the patient presents to us, we will assess with the routine basic blood, and also we'll do a tumor marker like LDH and AFP HCG, beta HCG, just to differentiate from germ cell tumor. Then we'll be start with image scrotal ultrasound to identify the location of paratesticular location, and also give us idea about the like characteristic of the mass. And then for abdominal CT cross-sectional image or MRI. CT will be better for identify the node, retroperitoneal lymph node involvement, and MRI for the primary tumor. Chest CT for staging. So here the role of PET scan. So it's widely used in adult population, but limited experience in pediatric population. When the PET scan combined with CT has better sensitivity and specificity, but the diagnostic accuracy to identify the regional lymph node is still poor and give you some false positive. So still we need to do retroperitoneal assessment and histological confirmation. As we see here, they compare the detection, compare the sentinel lymph node biopsy versus PET scan, and we see the sensitivity and specificity here at 57 to 52%. Actually, I saw like other articles, actually it's higher than this. And also in the 3 group COG, European and German, I will mention the article in the coming slides. They think it's promising PET scan to detect the lymph node. However, still for only investigation. Okay, so histology, we have we have embryonal histology is the 80% of paratesticular tumor, and the subtype in the embryonal with paratesticular it's spindle cell, and other histology like alveolar and polymorphic. Alveolar associated with worse prognosis if it's fusion positive, and there is 25% of alveolar fusion negative have similar prognosis like embryonal. Medical treatment, all the rhabdomyosarcoma patient in any location will be, or any site will have adjuvant chemotherapy. The radiation therapy, it's used for patients with lymph node mets, and there is other indication, it will come in the coming slides. So for the patient, if we are suspected paratesticular, so our approach will be, depends on how the patient presents, depends if we know, if we think this patient paratesticular tumor, rhabdo, so then we will do radical inguinal orchidectomy with high ligation of the cord. And we need to assess the retroperitoneal lymph node if the patient 10 years of age or older, as around 32% of 10 years, they will have positive retroperitoneal lymph node, or if there is evidence on the image. So group 1 completely resected embryonal tumor will not require radiation therapy. And if there is tumor spillage, the tumor will, the clinical group, the staging will upstage to 2A. So this is just to mention the principle of inguinal orchidectomy for tumor. So radical orchidectomy will be through the inguinal approach, as we avoiding the transcrutal because it's increased risk of tumor spillage. There is it will be difficulty to go to high ligation of the cord, and if we do transcrutal biopsy, as we know, we spread to the lymphatic to the inguinal. So also care need to be taken not to breach the tunica vaginalis at the internal ring, and we remove the tumor as a single specimen. The cord should be clamped at the internal ring before mobilization, and cord ligated with non-absorbable suture and left lung tag more than 2 centimeters for possible retroperitoneal lymph node assessment or re-excision. So we, for the if the tumor invade the skin, we need to resect the scrotum as hemiscrotumectomy. I will go through now the next slide about that. Testicle preservation is not for paratesticular tumor, rhabdo, and large tumor. We need to extend the inguinal incision down to the scrotum. So this is the study that I mentioned with the COG and European and also the German group. This is the release guideline. It's actually a nice article. I got a lot of information from there in 2022. So the transcrotal excision, scrotal violation, hemiscrotumectomy. So if the patient has previous transcrotal biopsy, the new guideline now is not to do hemiscrotomectomy. We do it only if there is invasion to the skin, and also if there is a microscopic residual, we don't need to do hemiscrotomectomy, and the patient might have only like radiation after that. So testicular transposition, if the patient group 3 disease, and the patient will have radiation therapy to the scrotum. So for the contralateral testis, we need to do testicular transposition. And there is other, also, we should consider that even in fusion positive patient. Pre-treatment re-excision is relock surgery before starting chemotherapy. If the patient referred and inappropriate surgery or unclear margin and or only biopsy, and the surgeon think that we can resect the whole tumor, so then you will have actually the patient will be converted. If we do complete resection, it will be the same outcome as the patient who had primary group 1 resection, like complete resection from the first time. And for delayed primary excision after chemotherapy, if we think the residual can be resected, the same principle with to go safe, and we are not causing any any injury to the other structure around but will not improve the outcome, but will reduce the subsequent radiation. So if we think the patient will not have microscopic or complete resection, and we still have gross residual, so then we shouldn't do that, as the patient will also need full radiation therapy. So lymph node approach. Here the pooled analysis of the North America and European, and they like recommend surgical assessment for regional node is important for patient more than 10 years and patient with positive node. We already mentioned that as affect the event-free survival. The European group, previously they weren't doing routine assessment for retroperitoneal, but then after they found that improving the now it's changing. And this is the bold data from both groups. So the principle in retroperitoneal lymph node assessment, so we can do it open laparoscopic, depending how comfortable you are with laparoscopic, and to excise any residual spermatic cord, that the sum that we left, and staging procedure, so it's not formal nodal clearance. We need 7 to 12 retroperitoneal lymph node, particularly near to the ipsilateral renal vein. We need to mark the boundaries with clips for future radiotherapy. And alternatively, we can do sentinel nodal evaluation by injecting through the tumor or at spermatic cord. But that doesn't mean that we don't need to, we still need to do sampling of like around 7 to 12. So for management of metastatic rhabdomyosarcoma, it's about 10 to 20% of pediatric patients. It's also one of the poor prognosis. But if the patient has metastasis, we still need to remove the primary tumor, even in MITS. And as you see here, the aggressive local surgery plus radiotherapy will improve the overall survival to 44%. And if it's surgery alone will be 18%, and radiation alone will be 16%. This is a list of prognostic factor for rhabdomyosarcoma: absence of METs, fusion negative, embryonal or botroid histology. This is in general botroid, which is more for the genital, like vaginal, and favorable primary tumor site. Tumor size less than 5 centimeters. Complete resection of the tumor, age from 1 to 9 years, and longer interval time to relapse. So the outcome for a patient who had radical inguinal orchidectomy or lymph node and lymph node dissection chemotherapy and radiation therapy, it's good, 96%. And hopefully the most paratesticular tumor patient present with stage 1. I'm not sure about, I didn't actually look at like in South Africa, but this is from the US. And the younger patient has better survival than adolescent. For advanced disease, METs or like bigger tumor or unfavorable histology, the overall survival is 25 to 30%. So for follow-up, every patient will have a follow-up. And for the routine image for follow-up, it's controversial, as this study shows that detecting an image, the relapse before the symptom present, will not change the outcome. Okay, thank you very much. I think I'm talking fast, 17 minutes only. But if you have any question, please ask. And this is the reference.
Thank you, Abdullah, for the talk. Do you have any questions on the floor? Any questions in the chat that you would like to ask? Anything from my side? We have a question from Prof. Lazarus.
Okay.
Hi,
yeah.
Hi, Abdullah. Thank you very much for being prepared to talk on your time off. Thank you for a very well put together talk. I think this is a topic certainly for urological surgeons that comes up in the exam. In fact, we had a case at our CMSA exam this last week that covered RMS of the paratesticular area. I think it's important just to clarify. You said there were only 2 subtypes, but there are in fact 4, aren't there? Just do you want to go through them and perhaps characterize those subtypes? That's perhaps the first question. And a second question, if you can just reflect on this unusual situation where for paratesticular, we're required to do a retroperitoneal lymph node dissection if they're more than 10 years, but less than 10 years not. Did you read anything to explain that?
Yes. Thanks, Prof, for the subtypes. Actually, it's a spindle, and there is other subtype. Unfortunately, I cannot recall it now, but I will look for it. For the question about, because it's a bit, the other question I read around it, and there is question before about if PET scan enough, and I looked at PET scan if it's enough to like for us not to do the retroperitoneal lymph node sampling, but where I looked, it still need to do a retroperitoneal assessment. And when I looked at the also the last guideline that I mentioned there, it's they still recommend that PET scan only investigation, and we still recommend that to do retroperitoneal dissection for more than 10 years and for positive patient, like if there is positive in the image. Yeah. I hope this answers the question.
Yes, no, I think that's fine. I think the situation is that more than 10 years, they've got quite a high chance of having occult mets in the retroperitoneum. I haven't got a percentage. And secondly, more than 10 years, the histological subtype is not usually the favorable embryonal, but in fact it could be alveolar, if I'm correct. We need to check that. But the point is that it's much more likely that they occult mets more than 10 years, and that's why it's recommended in the adolescent as opposed to children younger than 10.
Thanks.
Thank you, Prof, for that. Any other questions on the floor? I don't think so. Thank you, Abdullah, for your time. We are going to move on to the next speaker. So our next speaker is... So our next speaker is Dr. Pule. He's one of our urology registrars here at Groote Schuur. Dr. Pule will be speaking on posterior urethral valves. He'll be providing us with an approach and an overview to one of the most important congenital causes of bladder outlet obstruction, as well as renal impairment in the pediatric urology setting. Although it's a commonly encountered condition within the pediatric setting, PUV still continues to carry a significant long-term implications. So it's important for us to recognize it early and have appropriate management options in place. Thank you, Dr. Pule.
Thank you, Dr. Aman. Good morning. I'm Dr. Pule with Urology at UCT. I'll be presenting on posterior urethral valves. As Dr. Aman rightfully said, it's one of the congenital anomalies that carry significant morbidity as these kids age. So just a bit of background. This entity has been described for more than 200 years. First described by Mgogni in 1769, who first recognized it while doing postmortems. It was then again seen a few years later by Langenbeck, who confirmed what Mgogni already saw previously. And then was our Dr. Dr. Yug Yang, who did the first endoscopic diagnosis of posterior urethral valves, and then gave us the classification at the same time, which we are still using to this day. And then the following year in 1920, Dr. Randall did the first endoscopic resection, and then also went on to describe the posterior urethral valve, how it is, the high bladder neck, the verumontanum. He beautifully described it. If you want to look it up, it's in Campbell's, it's laid out there. And then in 1982, we have Michel who coined the word bladder valve syndrome, describing the vicious cycle that the bladder undergoes as it decompensates. I'll get into those details as we move on. So just a brief epidemiology. So lower urinary tract obstruction has an incidence of about 2.2 per 10,000 live births. And of note, PUV accounts for most of those anomalies, followed by Brun-Bailey syndrome and urethral atresia. Of note, 1/3 of patients with PUV will go on to develop end-stage renal failure, which is why it's of such importance that we catch on these patients early on and we treat them aggressively to prevent them from reaching that endpoint. So the prevalence, in terms of the prevalence with regard to ethnicity, has been noted to be slightly higher in the Black and minority ethnic groups when compared to the Caucasians. And the overall incidence ranges from 1.6 to 2.1 per 10,000 live births. So going back to Young's classification of PUVs back in 1990, the type 1, which I'll show shortly, accounts for about 95% of all the PUVs. It's basically leaflets arising from the verumontanum, taking an anterior route and planting itself just slightly proximal to the external urethral sphincter. And then type 2 is non-obstructive. They actually don't like putting it into the classification, but it was originally there, so we prefer to leave it there. It's basically described as leaflets extending from the verumontanum posteriorly to the bladder neck. And then type 3, which is simply, for lack of a better word, you can think of it as a congenital posterior urethral stricture. It's circumferentially attached to the urethra with a pinhole in the center. So that's the original depiction that was shown by Young back in 1919. Type 1, as you can see up there, going from the verumontanum to the external sphincter. Type 2 going backwards to the bladder neck, and type 3 being depicted by that circumferential membrane with a center in between. So just a bit of a touch on the embryology. So as we know, the cloaca separates into the urogenital and the anorectal sinus at 4 to 6 weeks. And then the urogenital sinus then goes on to become the urethra and the bladder. So the Wolffian duct fuses early on with the cloaca at about 4 weeks of gestation. And then how this PUVs occur now is that there's abnormal insertion and migration of the orifices of the mesonephric duct. And this is usually when they are too anterior, resulting in abnormal ridges or valves in this case. So several theories have been put forward to try and explain how these how these posterior urethral valves come about in the past. So we don't need to go through all of them, but one thing they did mention the abnormal development of the Wolffian Mullerian duct, and also Prof. Diwan et al. In 1994, a long time ago, described POCM as a persistent oblique urogenital membrane that is usually punctured at the time of placing a urethral catheter postpartum. So this is in keeping with what we think in type 3. He also went on to postulate that the posterior urethral valve is a single membrane, and that the type 1 and type 3 are probably a spectrum of the same entity. Um, moving on to the genetics of PUV, PUV has now been found to have a genetic cause or genetic preponderance. There have been identified chromosomes like chromosome 11 and chromosome 1 in cases of familial PUV, and they are also looking into the fact that it might be transmitted, inherited via autosomal recessive, X-linked, recessive, or multifactorial genes. The understanding of PUV genetics is still at its infancy at this point, and we are still awaiting more data from the researchers that are ongoing with regard to PUV and genetics. So what exactly happens with PUV? So we have an outlet obstruction. These are the PUV. That's a posterior urethral valves causing outlet obstruction, and then the bladder tends to hypertrophy as a way to compensate for the increased voiding pressures. And then initially this seems to work. Patients able to void, and then with this obstruction later on comes the remodeling of the detrosa, the extracellular matrix being deposited, along with fibrosis in the long run. With fibrosis stepping in, now we have this altered contraction and relaxation, which now prevents the bladder from emptying or storing enough, and hence the vicious cycle, which we are going to talk about later on. There are 3 patterns that have been recognized in kids, in pediatric patients with PUVs. There's detrosa hyperactivity in the early stages during infancy, decreased pressures with improved compliance as they get into childhood, and then with adolescents, there's increased capacity with hypocontractility or anatonic bladder as we have it. Going on to the bladder valve syndrome, coined by Michel in 1982. So it's being led by three factors: polyuria, bladder insensitivity, and high post-void residuals. So there's bladder outlet obstruction, detrosa hyperactivity. There is high pressures for which the bladder is compensating for, and then now there's this progressive remodeling of the bladder wall with fibrosis, and this now leads to the bladder being unable to completely empty or contract, and then this leads to increased post-void residuals as the bladder is always as there's always urine in the bladder. Then there's now sustained stretch. The bladder wall is always under pressure, and now this leads to collagen deposition, And this collagen deposition leads to high pressures being within the bladder, and these pressures are now being transmitted into the upper tracts, leading to now the polyuria or worsening the renal dysfunction. So this is the cycle, how it goes. More urine is being produced, the bladder is not able to evacuate it. More urine is left in the bladder, and then this pressure is transferred to the upper tracts. The upper tracts suffer more, produce more urine. That's the viciousness of the cycle. One thing leads to the next, but eventually it all goes back to the beginning. And then with regard to the upper tracts and the renal dysfunction, there's high intravesical pressures which are transferred to the ureters, and from the ureters to the pelvis. There's tubular injury, which leads to poorly concentrated urine, hence the polyuria. And then there's loss of concentration gradient, which again explains why the patients often have this polyuric phase. There's also the renal dysplasia, which starts off in the early prenatal stages, antenatal stage, that we should be aware of. So it's kind of also feeds back to the, in a vicious cycle, back to where we came from. And then there's the next thing is VUR, which presents in about 50 to 8% of patients with PUV. And this VUR is secondary to the bladder, elevated bladder pressures. So if you simplify it, all these problems they are caused by the PUV, but the bladder is like at the center of all of it. So we have to also in the management, you'll see that we are focusing a lot on the bladder to try and address all of these problems that are coming up. So this VUR is now secondary to bladder dysfunction, and it seems to improve in about 25 to 40% once you deal with the bladder, or you deal with the outlet obstruction, or you do a vesicostomy. And sometimes, even after you've dealt adequately with the bladder, there might be residual dilatation of the ureters because of the chronic insults, the wall thickening, loss of peristalsis, and mucosal coaptation failure. And then there's the Wirtz syndrome, in which there is now the one system or one side, usually the poor performing side with the dysplastic kidney, acts as a pop-off or sacrificial lamb in this case. So sometimes it takes on the pressures, the elevated pressures are transferred to the poor side, and there's a pop-off there. Somewhat, the other kidney, contralateral kidney, will be looking normal or somewhat be looking functional. It's not protective as we used to think, in the sense that these kidneys have been undergoing a dysplastic process even antenatally. So it shouldn't give us that false hope that nothing is happening. It would actually get us to follow them up more closer. These patients, one would wonder, how do we diagnose them? For newborns, if antenatally because of the ultrasounds being done increasingly now, thanks to the more available ultrasounds and upgraded antenatal care, more of these are being caught on early during antenatal visits. And PUVs are detected in about 1 per 1,500 ultrasound scans. So on the ultrasound, what we are looking at is that the thickened, dilated bladder, bilateral hydronephrosis, pelvic atelectasis, sometimes oligohydramnios might also be there. And then if you look at the bladder and the urethra, you might see the keyhole sign. I'm not sure if you're able to see it from here. Yeah, actually it's there. And also increased renal echogenicity, which is a surrogate for or which might represent renal damage. Other investigations which we can do antenatally can be a fetal MRI. Doesn't give that much of it's not going to change your management that differently from when you do an ultrasound, but it is something to look into. It gives you more detail, anatomical detail, in the sense that it can detect lung hypoplasia and renal cortical cysts if they are there. But the limitations in both these studies is that they can't they can't differentiate well between a PUV, urethral atresia, and Bruin-Bailey syndrome. So they tell you there's a problem, but they don't specify what exactly is the problem in some cases. And then postnatally, you can still do an ultrasound, see a distended bladder. The similar findings on ultrasound when you compare it to the prenatal ultrasound. Postnatally, though, the good thing is that we can do what's called a voiding cystourethrogram, which will show us elevated bladder neck, dilated posterior urethra, and also give us a bit more detail into what's going on inside the bladder with regard to trabeculations, diverticules, thickening, along with vascular-ureteric reflux. Another thing that can be done is a contrast-enhanced voiding urosonography, which uses enhanced contrast gel. It's nice in the sense that it's not using radiation as we do in a VCUG. In terms of lab findings, we usually postnatally we do a creatinine within 1 month, 6 months, 1 year as prognostic benchmarks. We avoid doing creatinine in the first 48 hours as it just reflects the mother's renal function instead of the baby's. And prenatally, as the fetus, when we do an ultrasound and we see that we are suspecting PUVs, we can take fetal urine and look for sodium chloride, osmolality, and the beta microglobulins. All this will help us decide if we are going to intervene antenatally or not. So what interventions can we do? Some have suggested that we can do vesicoamniotic shunting, and this is in the case of oligohydramnios, dilated bladder, severe hydrouretral nephrosis. The catch is that the karyotype has to be normal and has to be a male also. We don't usually advise it. They don't usually advise it if the renal cortical cysts, and they want a favorable urine biochemistry. A trial that was done before, the Pluto trial, showed that there was survival in the shunted group, but the outcomes were poor. About 40 to 50% of patients had fetal losses. Sorry, of 40 to 50% fetal loss was experienced in both groups. And then a fetoscope can also be done with YAG laser to cauterize the valves. The downside of this was that also, like the first one, there were pregnancy losses experienced in both sides of the study. So what do we do immediately in the postnatal setting? We usually have to try decompress the bladder. We put in a 5 or 7 French feeding tube, and we try to avoid putting a catheter with concerns of bladder spasm, obstructing the urethral orifices. The biggest cause of mortality post delivery for these patients can be pulmonary hypoplasia. So this kid will come hypoxic, will need higher level of care than the urologist, probably ICU care, nephrology, a multidisciplinary team immediately after birth. So this is just the EAU approach to a newborn with suspected PUV. So they advocate for immediate ultrasound post-birth, bladder drainage in the form of a feeding tube and antibiotics. And then depending on whether the patient is stable or not, we have to refer to the multidisciplinary teams. On our side, once the patient is stable, we do a voiding cystourethrogram, confirms the findings that I mentioned earlier on, and then we do the valve ablation within a few days or within an immediate setting. If the baby improves, then we monitor closely. As per the EAU guidelines, we monitor closely. If he doesn't improve, we check for residual valves, and then CIC if not emptying properly. So this is from the EAU, as I mentioned. Surgical intervention, how we do the valve ablation, we can use several techniques at our in our armamentarium. We have the the infant cystoscope. We can use a laser, the YAG laser fiber, the bougie fiber electrodes. So we usually do 5 o'clock, 7 o'clock, and 12 o'clock initially. And then there are times when when the infant is so small, it's difficult or it's not possible to put in a cystoscope. So in cases like that, we can use the Padua approach where you do progressive urethral dilatation, 5 to 8 French over 3 to 5 days. And then we usually discourage a hot loop resection due to higher urethral strictures. So that one has to be used with caution. And most places advocate for a MCUG at 1 month after ablation to check for valves and bladder wall thickening with reduced upper tract dilatation. What we do here, and when I say here in Red Cross, is that okay, we have this paper, this really nice paper that we published in 2023. It was published by Dr. Jim Jumbi and Prof. Lazarus. So the aim of this paper, of this study, was essentially to assess the prevalence of residual valves post-index resection, and also to see if reablating those valves made an improvement in terms of the creatinine and the upper tracts. Based on when you compare the AP diameters from the previous studies. What we found was that there was a prevalence of 77% residual valves, which is quite significant. And reablating those valves led to significant improvements in creatinine and AP diameters. So in our institute, we advocate for when you do the index ablation today, you should do the repeat ablation within 6 weeks of the index ablation, and then we monitor after that with serial ultrasounds. And depending on what we get, we will get more investigations on board or reablate, do a reablation with a bladder neck incision. It really depends on what we see on the second cystoscopy. So, and then we have the vesicostomies. A vesicostomy, basically, we try to preserve it as a bailout procedure. We use it when we can't do immediate ablation, or when even after ablating the patient several times or twice with a bladder neck incision, we still have a patient with worsening upper tracts and renal dysfunction. That's when we do the vesicostomy. A properly constructed vesicostomy is good in the sense that it allows the bladder to cycle, and at the same time keeps the pressure slow in the bladder. So that's the advantage and the beauty of a vesicostomy in these cases. Upper tract diversions, I haven't personally seen one, but we do upper tract diversions if need be. Usually in cases such as worsening renal dysfunction, despite complete lower tract decompensation. So your vesicostomy usually has to fail before you get to that point. Because it's and high diversions, we can also do them, but we usually shy away from doing them because they have no long-term benefit, and the operation to undo them is usually a great one, or requires and is usually very complex. With regard to circumcision and VUR, the EAU advocates for circumcision in cases of recurrent UTIs in a patient with PUVs. It's been shown that circumcision reduces risk of PUV by 83 to 92%, and it's strongly recommended by the EAU. VUR, as I mentioned before, it's mostly a problem. It's secondary due to the bladder. So if you address the bladder, you address the VUR. So we try to advocate for more aggressive management of the bladder in our institute to try avoid worsening VUR. And it has been shown that reflux improves in 24 to 40% of patients after doing a lower tract diversion or doing a valve ablation. So with regard to bladder dysfunction, we have to, of course, involve the family as the primary caretakers. We try to not push patients too hard to be toilet trained. Remember, they're not our usual patients, and we have to be a bit more, it will put extra psychological and bring other factors into play when we try to force early toilet training. So we do encourage it, but not to push aggressively. What we do also want them to do is urotherapy. You tell them timed voiding 3 hourly if possible, actually not if possible, 3 hourly, and you tell them to double void every time. We try to instill or teach them pelvic floor exercises if they come of age. And then we usually do bladder neck incisions and try to not give them too many medications, but if there is what we see on, if you do an VCUG and we know that there's a hypertrophied bladder neck, we can start them on alpha blockers to try relax the sphincter, sorry, the bladder neck. Oxybutynin we do give, but we have to be cautious when we give oxybutynin in a kiddie who's not doing CIC yet. So they usually need very close monitoring. If they have high residuals, you stop the oxybutynin immediately so that he doesn't go into retention. And it's also been shown that there's room for mirabegron in the management of these pediatric cases. With regard to the UDS, UDS is that video UDS is that tool that really helps us manage these patients, because sometimes the history, even if you do a thorough history taking, it's not really giving us a good picture of what's going on in the child's life. So a UDS is more representative. You can tell the pressures. Is this kid having high bladder pressures? And it can help you plan the management, especially in cases of worsening upper tracts, renal dysfunction, recurrent UTIs, or a situation where the clinical picture has now changed. You don't know what's going on. UDS is the way to go. Sorry, along with it obviously encapsulates a uroflow and a PVR. So other techniques or other things we can do to try improve the bladder is an overnight catheter. It breaks the vicious triad, the vicious cycle in the sense that it lets the bladder rest overnight. Nighttime is about 14 hours, okay, depending on what time you sleep. Let's say 8 hours. So 8 hours out of 24 hours of rest, that's a lot. That's 1/3 of the day. So it allows the bladder to rest for a few hours before allowing it to cycle again. Other things we can do are CIC, which we do when every intervention has failed and the patient now has an atonic high pressure bladder. We can advocate for a CIC. Matrophnov, we can advocate for it also, especially in cases where patient is having a difficult time doing the CIC, but they are motivated to do the CIC. So the underlying word there, which I really find useful, is that they have to be motivated to do the CIC. There's no point in doing a trough and the next thing patient's not doing the CIC. So we really have to make sure that they are motivated. And then in terms of blood augmentation, we prefer using urethral augmentation over the ileal, because ileal augment, because of reduced side effects or complications such as mucus, acid, and stones. This is mostly reserved for patients with small bladder capacity and bladder and high pressures despite all the other interventions. So we usually use the nitrocreatinine taken at 1 year as a prognostic marker to see if this patient is going to develop end-stage renal disease. We put them in a bracket of high, very low, or this one, or high risk of developing end-stage renal disease, along with the initial ultrasound done. If it has any cysts and loss of CMD, then these patients are at high risk. They are poor risk. They're they have a poor prognosis and are at high risk of end-stage renal disease. Now, some of these patients, as I mentioned before, the 1/3 of them will go on to develop end-stage renal disease, renal failure. Transplant is something that we always have to have at the back of our minds, because if the kidneys don't work, that's the last resort. So we have to do a baseline UDS before doing a transplant for these patients. UDS helps in the sense that it checks the bladder pressures, checks the contractility of the bladder. It helps us to know, are we putting this kidney, are we planting it into a good or healthy bladder, or do we need to buy time and address the bladder issue first? Remember, like I said before, bladder is the main problem here. If the bladder malfunctions even in this kidney, it might even lead to it going or being having graft failure sooner than you would have otherwise with a normal or nice functioning bladder. So there's also the issue that sometimes we need to do nephrectomies of the pre-transplanted kidneys before we do transplant. This is because sometimes they are polyuric, they're still pouring, and it's of no value now. You put a new kidney there and the other kidneys are malfunctioning. And also it might cause them to be hemodynamically unstable. So with regard to quality of life, this is something we need to touch on. It's been found that about 15 patients with PUVs have neurodevelopmental disorders, and 9% of them were diagnosed with ADHD. So just something that maybe we should keep in mind, might also delay toilet training to some extent. We need to always be on the lookout to see, are these kids, how they are in clinic, and refer them to the relevant specialty. And then with regard to fertility and sexual dysfunction, they are just like everybody else. We can reassure the parents that fertility-wise, they can still go on to have normal families as everybody else. And sometimes they do achieve daytime, nighttime continence at a later stage when compared to the counterparts. This is usually at around 5 years of age, while the counterparts are around 2.5 years or 2 years of age. So it's just something we need to know so that we can counsel the mothers and the family, because they'll always come to us concerned. So in a nutshell, as urologists, we need to know this topic. We need to know, because once they transition from pediatric urology to adult urology, we are the ones who are going to take them over. We need to be well armed with what happened. We need to know where to go when what happens. So and also we need to know that this condition, it's a lifelong condition. Once a kid is diagnosed as PUV, they are our buddies. They will even know when they have kids. Trust me, they'll tell us, I have a kid now. And then just be like, does he have PUV also or not? So we develop such a relationship with these patients as they come to us over years, and we need to know how to help them when they need help, including how to address the problems they come with holistically. Thank you.
Thank you, Dr. Pule, for an excellent talk. Do you have any questions on the floor? First question from Dr. Opal.
Thanks very much, Pule. I think with regards to that fertility, obviously they do ask, is my kid going to be normal, similar to like a torsion? I think there is a slightly increased risk of sort of retrograde ejaculation in those kids going forward. So that is something they must be cognizant of. They got a bit of bladder neck dysfunction. So it's not 100% normal like the rest of the population, but there is an increased risk of that. One thing you commonly see when you're following these patients up, obviously we see them, we find out how they're doing, and we always book a sort of ultrasound every 3 to 6 months, is that issue of hydroureter, whether it be unilateral or bilateral. So how would you approach hydroureter in a patient? They say the child's voiding okay, the renal function, everything looks fine. How would you sort of counsel the parents on that hydroureter that you might see on ultrasound?
Thank you, Cliff, for the question. So in terms of the hydroureter, there are several, of course, tell the parent that, in my mind, there are several causes, including that there might be residual obstruction, but we've dealt with this. There might be bilateral high-grade VUR also, or this might just be mega ureters due to the insults from before. So 1/3 of these hydroureters usually don't resolve completely. And also this, like I mentioned, the patient has polyuria, is always producing. He might have developed these thick peristaltic ureters in the early years of childhood. How we can approach this is, one, we can do a VCUG, MCUG, just to check if there is reflux, or we can do a renogram to also check if we can also show if there is reflux and injury to the kidneys. Not all dilated ureters are obstructed as per the King's classification. So we can reassure them and work on them, especially if the renal function is preserved or there is no increased damage to the upper tracts. Not sure if I can give fair answer.
Yeah, thank you. I think that's right. You want to exclude reflux and obstruction, but usually with this chronic issue, there's sort of remodeling of that ureter, so they get this sort of non-obstructive hydroureter. And that's actually where the sort of famous Whittaker test was developed in this setting to work out why do these kids have this hydroureter. And it was this population which they performed that invasive test. Fortunately, now we've got renogram to sort of prevent having to perk these kids. But yeah, it's a common thing, and it's usually not going to cause much issues.
Thank you, Dr. Pule. We have a question from Prof. Lazarus.
Thank you, Dr. Pule. Very professional talk. You're sounding like a pediatric urologist, so that's good. Just a couple of comments. We also published some work related to the predictive marker of creatinine, which is quite an important NADA at the first year to tell you where this kid's going. And it's interesting because our figure was 80. So if it was more than a creatinine of 80, that implied they were going to end up in end-stage renal disease. And it was interesting to look at international stages because it seems to be independent of developed or poorly developed, because these kids often present, so they're often treated. And so our figures were very similar to overseas studies. The other thing that you didn't mention, which I'm quite in favor of, is to consider a bladder neck incision. I think that reablation, I think you provided compelling evidence why that's helpful. But, if the creatinine is still up, if the Groote on the table is poor, if the ultrasound still shows ongoing hydronephrosis, we would consider doing a bladder neck incision. It is controversial. There is slightly higher rates of incontinence. There's also some concern, theoretically, potentially for retrograde ejaculation later on. But there's a good study from a colleague from Iran, and he's done a lot of good pediatric urology randomized trials to compare bladder neck incision versus no, and they did have better urodynamic features at 5 years of age. So I found that quite compelling. Other colleagues internationally don't agree with that, but I think it's something to consider in kids who are in trouble. Just a last question for you. If you could just pull up that slide of the Pluto showing the amniotic fluid values, and perhaps if you can explain to the audience why the sodium and osmolality being low would be a good thing.
Okay, Prof. So this slide, so with the sodium being low, being a good thing, means that the kidneys are functioning. It means that the sodium is being filtered out of the urine, which confers to renal function or helps now in concentrating the urine, for lack of a better word. Yes, Prof.
So we accept that sodium is filtered, but it's also being reabsorbed.
Yes,
so
Prof.
A functioning kidney is able to draw back the sodium into the bloodstream, and very little is getting into the
Very little is getting to the urine.
And the same is applying to reducing dilute urine, suggestive of good kidneys.
Yes, Prof. It's basically a surrogate for function.
Thank you. Any other questions on the floor? I don't think we have any questions in the chat. So I think we'll close off the webinar for this morning. Thank you to both speakers for such excellent talks on pediatric urology. We'd like to thank everyone for joining us this week, and we will see you all next week for the next webinar. Have a good day.